The webinar. My name is Jillian Bartlett. I'm the Executive Director of the Network Coordinating Office of the Primary and Integrated Healthcare Innovations Network. It is a CIHR supported SPORE network that's based in primary care. And I'd like to welcome you to our network learning series. This is where we showcase some of the research that's being done across the country on topics that are important to the health and healthcare system of the Canadian population, and they often have lessons that can be learned for other systems and settings. So I'm going to give a few instructions on how a webinar works. You're on a Zoom webinar, so if you're joining us, you have two options for communicating with the speakers and myself during this webinar. The first is the Q&A box. If you look at the bottom, you will see a Q&A with two call out buttons. If you click on that, you can post a question there. You can make it anonymous or you can add your name. If you add your name, I will acknowledge your name while I'm asking the question to the panelists after they have finished speaking. The other way to communicate is the chat. If you click on that, you'll see that I posted a little welcome message. You have two options there. You can put a chat that everyone can see or that only the panelists can see. If you have comments instead of questions you'd like to share with everybody, I recommend you use the chat function. Questions, please put in the Q&A box. So that's how we will be doing the Q&A session, which will follow our speakers giving their presentations, and I will be moderating that session. One other thing I'd like to let you know, you can, if you're having issues with sound or anything like that, you can send a private message just to the panelists if you're having any technical issues. These recordings of this session and other sessions will be available on our website, which is will be listed in the chat by Anik Baudry as we go along, and you can go on there and get a copy of this. What I'm going to do before we open is read a virtual acknowledgement of territorial lands. This was a statement done by the Indigenous Working Group of the College of Family Physicians of Canada, and they were kind enough to provide that for us. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories that you're calling in from as we commit ourselves to gaining knowledge and forging new culturally safe relationship and contributing to reconciliation. And I know that today we have a great series of panelists, and we're going to be talking about integrated care, or the research that's been done around integrated care in Canada. And we have Nellie Olke. I'm sorry, Nellie, I forgot to verify how to say your last name. And she's calling in from UBC Okanagan. And she will be followed by Joan Tranmer. I'm really maskering names today, but I'm an equal opportunity masker of names. And she's calling in from Queens. And then that'll be followed by Jason Sutherland, who's at UBC as well, so out on the lovely west coast of Canada. And we'll have final comments by our patient partner, Joni Cranston, who's calling in from Newfoundland. So we have a good territorial representation today. So without further ado, I am going to turn over the mic and the screen sharing to Nellie, who is going to give a presentation on primary healthcare teams and integration. And this is a policy analysis. So Nellie, if you want to go ahead and share your screen, and the rest of us are going to stop our videos and mute ourselves. I'll let you know when we can see the slideshow.
You're good.
You need to go to the top on the display settings and change, because right now it's presenter view. So there's three things across the top. And if you go into display settings, that should change it so that we only see one slide at a time.
So let me try this again and see. Is that better?
Perfect. Great. Go ahead.
Great. Sorry about that, folks. Welcome. Good morning, good afternoon, and happy to be here. I would like to acknowledge that I live, work, and play on the unceded and traditional territories of the Okanagan Silks Nation. So this is our team that is part of the project, and also acknowledge that this project was funded by CIHR and the Michael Smith Foundation for Health Research, and also UBC Okanagan. So just as background, improving health services integration for patients with complex needs continues to be a challenge. Their primary healthcare teams are used oftentimes to address these needs, to better improve the patient experience, to coordinate care, sorry, improve population health, and then also in trying to improve and reduce costs. Primary healthcare teams have been implemented in very diverse ways across Canada. And the impact of primary healthcare teams on outcomes, including integrated services delivery, is still mixed. And so there is mixed evidence around that. And there's little evidence on what policies and structures facilitate, incentivize, or promote integrated service delivery for patients with complex needs. And this project occurred in 4 provinces across Canada. So these were the research objectives. So first we wanted to look at policies and structures and what facilitates development, implementation, and sustainability of team-based primary healthcare models that focus on patients with complex needs. The second was to look at and identify performance indicators, and then also to look at policies and structures, roles, governance, and performance measures that supported or acted as barriers to integrated service delivery through primary healthcare teams. And lastly, we also looked at patient engagement and how patients were engaged and how they wished to be engaged in policy development, implementation, and evaluation. So there are 3 phases to the study, and we are in the midst of phase 2, given the challenges that we've faced with COVID and that everyone has faced. So in phase 1, we did an individual and cross-case policy analysis looking at policies over the last 10 years, both macro and meso level policies around primary healthcare teams and integration. And then our second phase was looking at patient engagement and policy development. And we did interviews. Some of those are still occurring across the provinces. And then to culminate in a deliberative dialogue in each of the provinces to discuss how we move forward and co-create solutions around patient engagement in policy in this area. And then lastly, which will happen probably in September, a national interactive KT event. So there were results from the policy analysis where there are 5 sort of key themes that are aligned to the 10 key principles for integration. And so the first was patient focus. And so patient partnership and the creation of policy was certainly evident in the policies that we reviewed, but there was significant variation on how those patients were engaged, and particularly lack of clarity on patient engagement, especially in the implementation and evaluation of policy. We often saw patients involved in policy development, strategic direction, et cetera, but then there was no follow through beyond that. We saw in BC some specific attention to the First Nations policy through, or populations through First Nations Health Authority. And then Ontario, definitely a significant patient engagement through their advisory committees in the LHINs, which of course now are in a much different format than previously. So looking at standardization of care through teams, as I've said, the team infrastructure varies across provinces. There's a mix of professionals and skills locally responsible and appropriate for the population, but also there's a lack of information in policies on how population needs are determined and used then to determine the mix for the team. Alberta recommended a 3-to-4 to 1 ratio, so 3 to 4 allied health professionals to 1 primary care physician. But most of the teams in that province and elsewhere are still at that 1-to-1 ratio. A common barrier that was raised was that providers were not working to optimal scope of practice, particularly non-physician healthcare professionals, and that there was a lack of clarity in roles. Information systems, there's definite variation in the use of information technology. Quebec had invested in a single system. We see some movement in Alberta more recently, but there are still significant challenges and incompatibility. And electronic health records were acknowledged that they are key to providing continuity of care and improving communication between team providers. Essentially, team-based care is very challenging if you do not have a electronic health record that is shared and across providers. And electronic health records have the potential to also increase ways to communicate with patients. So there are options for email consultations and things like that. And then lastly, technology and telehealth have the potential to improve timely access for patients, particularly those in rural or remote areas. And we've seen obviously significant a movement in that approach given the pandemic. Performance measurement. There is an overall lack of focus on indicators and measurement in the policies. Provinces that were more advanced in primary healthcare reform, such as Ontario and Alberta, you saw more emphasis on evaluation. And so in Ontario, there was a focus on prevention screening and comparing models within the province, and Alberta focused on measuring emergency visits, chronic disease management, and medication prescription patterns. And again, that in order to have a strong performance measurement system or structure, you needed a functional EHR to be able to assist with measurement and data. Finally, our results in phase 1, we looked at financial management. There was no province that had a single compensation model for all primary healthcare teams. You saw in Ontario a significant focus on family health teams, and Quebec, the family medical groups. We're not suggesting that a province needs to have a single model, but that there is absolutely a difference across provinces and within provinces as well. Remuneration models not addressed in the policies and were often counterintuitive to team-based care, such as fee-for-service. Policies showed early consideration and development of more innovative funding models for primary healthcare teams. BC, for example, is looking at value-based care. And there were clear guidelines that there were not clear guidelines or recommendations for funding for primary healthcare teams. So this then focuses on the phase 2 results, and I have to say that these results are more preliminary. So there was a lot of information around patient engagement. And so patients, our participants felt empowered when their voices were heard, but that engagement was found to be tokenistic at times. And that was often, that was the same whether it was in a practice setting or in a policy environment. Most of the participants did not think there was a formal health team, and this is not new. Their family doctor was their main point of contact. And they found that frustrating because they oftentimes were the information carrier to all of their different team members, because the team members didn't necessarily communicate. There was a lack of communication, coordination, and cohesiveness between the healthcare team, which was found to be a major gap in primary healthcare. There were lack of opportunities to provide feedback for policy and practice changes. And when a person was asked for feedback, they were unsure if that feedback was really being used for policy change. Participants desired the opportunity to be involved in policy, but there were mixed results in their ability to participate. And the last really talks about the barriers that exist with regards to being able to participate. And so those are things such as access to opportunities or not being aware of opportunities. We need to consider patients' health condition and their ability to be able to participate. Communication skills, time constraints, bureaucratic red tape, tokenism we've already talked about, but then things such as racism, ageism, and lack of diversity in recruitment. So this slide here shows the 10 key actions that, or 12 key actions that were developed in our deliberative dialogue in BC. And I won't go through them in detail, but these are very, very interesting and not surprising, I don't think, but there was some interesting pieces. And so the utmost thing was to have to keep that patient at the center of the primary healthcare team collaboration, and whether that was in practice or in policy, et cetera. Being representative and inclusive, promoting real patient engagement. So meaningful engagement was really an important piece. They very specifically wanted to talk about case manager and navigator models because they really facilitated the care that they received. And, to get feedback from patients on policy at all levels. So whether it was actually having a short little survey in a physician's office, or where they could participate, or then participate on an actual committee, those were different ways that they felt that they wanted to be involved at different levels. Compensation. And then I think one of the really interesting things, and this is a very interesting piece around the patient-oriented research, is that we talk about how patients, the patient engagement around being involved in their care, being involved in research, but we actually don't train patients on how best to be involved in policy and policy activities, and maybe also find some of those activities as well. And then lastly, I just want to highlight clear definition of roles and expectations for patients. So if you have a patient or several patient partners on a committee or whatever, that they have clear roles and are actually invited to participate on a regular basis. And then closing the loop is really important around accountability. So in conclusion, there is variability in models and their uptake in Canada. There continues to be significant variability in policy related to primary healthcare teams and integration. I don't think the challenges are new. Funding models, the lack of interoperable information systems, but one of the significant gaps that continues to exist is performance measurement. And then the whole idea of patient engagement in policy has moved in the right direction, but there needs to be clarity of processes and particularly across that continuum of the policy process. So not just at development, but continue that through implementation and evaluation. The range of engagement opportunities needs to be increased along with the awareness of opportunities, and we need to address the barriers to engagement to have more inclusive representation. So thank you, and here's my email address, and I will stop sharing.
Thank you very much, Nellie. And if you don't mind putting your email address into the chat, people can contact you if they have questions, since your slideshow just disappeared. Next, we have Joan Tranmer, who is going to talk to us about evaluation of the components of primary care integration strategies for adults with chronic health conditions. So your screen looks great, Joan. So if you want to maybe put your video on, unless you have bandwidth issues, and unmute yourself, and you're, oh, it went back to your slide view. You were good.
I can't do two things at once.
Yeah, we're a year into Zoom and every single time, but this is what we have. It looks perfect. Go ahead, Joan.
Okay, here we go. Well, thank you very much for this invitation. I'm sitting here in Ontario and there's a snowstorm and it's cold, so I'd rather be out west with you guys. I'm going to report on a systematic review that we did with funding support from the SPORE network. And this was a collaboration between a team here at Queen's University and Memorial University in Newfoundland and primary care healthcare providers and decision makers. So Nellie, your presentation just set mine up perfectly. So it's quite interesting how there's common themes and threads throughout this challenge of providing system integration for our population. So the background to our review was that we know that there's strong positive association between system integration strategies and better meeting the care of patients, particularly those with complex healthcare needs. What we were interested in is there's a very poor understanding of the organizational attributes within integration strategies that are associated with both health and clinical outcomes. And so that body of literature was not synthesized. So the overall goal of our project was to conduct a systematic review to determine the organizational attributes of primary care-based integration strategies that were associated with optimal patient outcomes for older patients and adult patients with chronic health conditions. So we had two project objectives. Our first objective was to identify and assess the quality of the evidence regarding primary care-based system integration strategies and to look at the impact on patient outcomes. And then we wanted to synthesize the common organizational attributes across those effective integration strategies. So our approach, because of the complexity of the focus of integration and the wide body of literature, we searched for the most appropriate method to do this review. So we followed the Cochrane Public Health Group systematic review process because it was a community-based intervention strategies we were looking at. Our primary outcome of interest were measures related to clinical effectiveness, and we looked at measures related to both clinical indicators such as decreased blood pressure or self-reported patient outcomes such as patient satisfaction. We also looked at studies that included healthcare utilization outcomes such as emergency department visits and cost-related outcomes. Our independent variable or our variable of interest was any description of an intervention that was a primary care base, so not based in the hospital and not based in the community, but based out of a primary care practice. That it was an organizational strategy, not a patient-centered strategy, but an organizational strategy that included integration of system-level services across 2 practice sectors. And it had to be targeted for individuals with at least 2 chronic conditions. We looked at all analytical and descriptive studies that had outcomes of measure that we were interested in. So if it was an opinion report or a more descriptive study did not have outcome measures, it was not included in this review. We assessed the quality of the studies using a tool from a McMaster, and this allowed us to identify high and moderate quality studies. And then to synthesize the evidence, we followed a meta-synthesis approach and used a strategy called harvest plots, where we used the tone and height of the bars, and it will become evident later on to indicate the strength of the evidence related to that particular indicator of interest. So this is just your typical Prisma diagram. We initially looked at 2,000 studies, and this with screen of articles and looking at our inclusion and exclusion criteria. We came down to 32 studies that met the inclusion criteria. Of those, 3 we assessed as high quality, 13 with moderate quality, and 16 very, very low quality. The studies range from randomized trials to cohort to quasi-experimental and across a number of countries. This is, I'm just going to now report on both the moderate and high quality studies, which the number was 16. So we identified all those studies and their study ID. I'm not going to go through all those. Then what we use as our guiding framework is that we had recently completed a scoping review where we had identified the components and attributes of system integration. So on the left side of this figure, you see the dark blue boxes are what we are labeling the components of integration. And very similar to what Nellie just talked about in her policy analysis. So there were 5 components of integration, the major component being system level integration related to care coordination. Then we looked at the degree to which physician involvement was within the integration strategy, whether there was a single point of entry into the program, and whether there was support for information flow, whether that was electronic or communication, and whether there was some sort of component related to quality monitoring for performance. So with each of these components, we identified specific attributes related to that integration strategy. So for example, with care coordination, if there were reports related to a care coordinator or case manager, whether there was use of evidence-based guidelines, whether there was an interprofessional team to support the care coordination, support for self-management, whether there was provider-initiated follow-up rather than passive follow-up, and support for family and patient engagement. With respect to physician involvement, we determined whether there was active physician involvement, and this typically was the physician funded to be part of that in integration strategy, or whether there was passive involvement. And single point of entry, we looked at whether there was a systematic screening for patients to be involved in the program, or whether there was some sort of system of notification. For example, on discharge from hospital, if they met certain criteria, then were they referred to the primary care program. So with respect to data extraction, what we did for each study, across the top of the graph, you can see that those are the components of integration, and we identified in each study whether what the attribute within integration was. So this is an example of an intervention with the case management, care planning, and I'm not going to go through the detail, but we assessed that strategy, and there were two people that always assessed that there was primary care and home care were the sectors of integration. There was active care coordination, and that the intervention used care coordinator guidelines, interprofessional team, community resources. It was provider initiated follow-up and support of family, and there was active physician involvement. And there was a specified communication strategy. So we did that for all the 16 studies. So what did we find? So in most studies, there was some aspect of care coordination. Whether it was the most common element was the care coordinator, team support. 12 of the 16 studies have active physician involvement. 11 had some sort of a systematic assessment for a screening. And there was, most had some sort of support for a communication strategy, and very few had performance evaluation. So then what we did, we looked at, so this graph is reporting on the relationship of the strategies to self-reported outcomes. So if the study said there was improvement, then we classified that study as having better self-reported outcomes. If there were mixed findings, that there was some improvement and not, then that was classified as mixed outcomes, and no change in outcomes was the other category. So just to walk through this graph, you can see, for example, this study labeled as C. There is active physician involvement, there's care coordination, and there's information flow. So they had 6 of the integrated strategies, and they had, in that study, there were better self-reported outcomes. And so that you can see that there is variation in the number of strategies, and of course in the outcomes. I think I missed one. Okay, this is the healthcare utilization one. So again, the same sort of strategy of pulling all the evidence together. So with respect to improved healthcare utilization outcomes, you can see more were using the care coordination, information flow, where there was no change or mixed findings. You can see they were using some, but not all outcome, or not all strategies. With respect to clinical outcomes, again, you can see that where there was better outcomes, that there was a high use of strategies, and I forgot to report that the gray bars are the high quality studies. Sorry. So for cost related outcomes, Again, much the same pattern where there's not much change across the number of integration strategies and has very little impact on cost. So when we pulled all this together, we summarized that integration strategies are certainly multi-component and they involve complex organizational attributes. Unfortunately, few of the studies met the traditional quality standards. However, when we looked at the moderate to high quality studies, there was a trend in the, I should have shown this better. There was a trend towards better self-report and healthcare utilization with the higher quality studies. Care coordination, active physician involvement, and information sharing mechanisms are consistent attributes of integration across the studies associated with improvement. So given the complexity of both integration mechanisms and health system context, we postulated that effective integration can occur better when interventions are introduced and sustained with the appropriate component mechanisms, i.e. care coordination. And there's a need for a supportive context in which the intervention is allowed to evolve and adapt. And that innovative evaluation strategies are required to determine effectiveness. Just like to make a comment now within Ontario, we're going now through our Ontario Health Team transformation, which are supposedly designed to support better integration. So I'm working with our local Ontario Health Team here. And while this review was a bit dated, it's what I've shared with them is, the need for all the components, and it's really is informing some of our strategies as we go forward. Oh, so I'm done.
Thank you very much. And while our next speaker, Jason Sutherland, pulls up his slides and gets organized, I do want to note, I forgot to mention at the beginning, that this particular webinar is co-hosted or supported by the BC Primary Healthcare Research Network, which is one of our 10 networks that are incorporated within PIHCI. So Jason, are you good to go? We always worry. We've lost people into the virtual void as we're doing these seminars. So Jason's going to be speaking about assessing and learning from policy innovations for funding integrated care for chronic and acute conditions. So as you can see, all of these talks are very complementary, and it's really trying, how do we move forward integrated care? So I now see Jason, and I'm sure we can hear him. He'll just pull up his slides.
Yeah, sorry there, folks. Okay, can we see me?
We can, but you need to go up and change your view because we're seeing two slides at once. Believe it or not, everybody, we figured this out before, and it seems like our computers just revert back to the way that it wants to do things. So if you hit the slideshow, and if it does it again, which it is, at the top of your screen, there's three things. One is display settings. If you click on that, you can go down and flip the display settings. There you go. You're all good to go.
Okay, thanks everyone. Sorry for the technical problems. I'm usually at fault for that. So the title of the talk today is Assessing and Learning from Policy Innovations for Funding Integrated Care for Chronic and Acute Conditions. I'd like to acknowledge the funders of this are the PIHCI SPOR and the Michael Smith Foundation for Health Research. I have no conflicts to declare. I do not receive any remunerated amounts for any activities I do. And essentially, the scope of what we're talking about is a review of the scientific and great literature regarding different models for funding and funding policies to facilitate integrated care. Now, there is a team associated with this project. The co-lead is Dr. PIHCI from the University of Calgary, and then we have a number of team members, including Sipade Suri, Akram Mahani, Maria Sleep, and Rohi Beach, co-located in Calgary and Vancouver, depending on where the work's getting done that day. So I have a few slides that talk about the overview of the healthcare system and why talking about healthcare funding policy for integrated care is important and relevant to the topic at hand today, building off the previous discussions of discussants materials, is that there is an absence of a national health benefit package in British Columbia and all provinces across Canada, mandated by the Canada Health Act to only include hospital-based care and medically necessary diagnostic and physician services. However, individual coverage decisions beyond the mandated necessary elements of that are made by individual provinces, resulting in a fair amount of heterogeneity on what is insured and who pays for different kinds of services, including home care, drugs, income thresholds, long-term care thresholds as well too. I will come back to the provinces have the responsibility for funding their own healthcare insurance program and its different elements, and there is no national or even provincial system, as I'm going to get into in a little bit more detail. Complicating that is that in a number of provinces, they have regionalized healthcare delivery as well too, and may have been with local health integration networks in Ontario, in its various stages, to health authorities in British Columbia, to single health authorities such as next door in Alberta. And these regionalized delivery systems are funded by the ministries of health and their provincial governments to organize and fund healthcare delivery within their geographic region, including under this broad umbrella, expediting access where necessary, ensuring quality and it's cost efficient, and the delivery of effective care to some degree as well too. Now, the delivery system is a very complicated environment as well too. We have primarily private actors in the healthcare system, although it is publicly funded. We have not-for-profit hospitals that are generally owned by the board or the region, physicians, which are primarily independent businesses, either solo or group practices, and they're paid directly by the provinces. Community-based private community pharmacies, where individuals seeking their drugs have different types of insurance, including public insurance, commercial, and or out-of-pocket. And commercial means employer-based. And then community-based care, which would include home care or long-term care. That is, depending on the provinces, very different levels of public health insurance, not-for-profits or private providers. So pretty complicated environment. And this is, a slide that I do talk about healthcare funding policy a lot about. This is essentially a synopsis of Canada's healthcare funding policy, in that governments put money in the different silos, and it's really hard to understand what happens in terms of the continuity of care or the integration of care, because everything is funded and paid for by silos. And here's a quick summary state of where we are. We pay hospitals in a single envelope predominantly, if you're not in Ontario. Physicians are paid for what they do. Long-term care, the incentives there are to have all the beds full with the least costly or least medically complex patients as possible. And home care, which is unrelated to outcomes or potential patients' maintenance of health status or gain in function or independence levels. So summarizing this is that healthcare spending across the different provinces have a lot of glaring problems. Everyone here is well aware of what they are. They're very complicated to fix, including some of the most significant issues that we find is that there's minimal accountability for within and between sector resource use, and there's no incentive for sector substitutions, which means changing up the mix of home care for long-term care, or hospital at home for hospital-based services. And there's one person that's essentially accountable for making those changes and for enacting or developing and implementing and making sure everyone's accountable for making those changes. And in my view, government and regions have shown no leadership and very lack a myopic vision for aligning the funding policies with the desired delivery system changes. And in fact, other than some changes in the primary care sector, there have been very few substantive healthcare funding reforms outside of Ontario in the last 3 or 4 decades almost. And complicating the factor is that government ministries of health themselves and also the regions are built and organized in these same funding silos. So ministries of health will have a physician services branch, a hospital services branch, and a drug branch. So all of these are aligned with how services are delivered, reflecting the complexity if we were moved to an integrated model that governments themselves would have to twist themselves inside out in how that they manage the delivery and funding of healthcare services. Now I'll get to the question of hand of the study that we were undertaking. And we were attempting to identify studies with evidence about different models, funding models of allocating monies to facilitate integrated care. This is an international review with few parameters around what type of evidence we would review. We had a number of key outcomes that we were looking for. So we wanted a complete enumeration of the type of models that governments or healthcare funders were using to allocate funds to facilitate integrated care. Which problems these models were attempting to address? Was it fragmentation? Was it continuity? Was it quality? So we were trying to also enumerate which were the policy problems they were trying to fix with these integrated care funding models. What were the barriers and facilitators of implementing new funding policies, and the evidence of the impact of success were something we looked for. And then at the fifth point, we were looking for policy lessons and opportunities for Canada. So here's a quick slide summary of what we did. We did a review of published literature and also the gray literature using a list of keywords. And this is not a comprehensive list, but it gives you some sense. Following the established protocol, we were able to identify 1,570 abstracts we reviewed. Of those, actually only 89 met the inclusion criteria for funding models associated with looking at and hopefully improving integrated care. So with the 89 published studies and sources of gray literature, most of it I can report is fairly new, and it has been published in the scientific literature since 2017. In fact, most of it is just coming out in the last 2 or 3 years. So this indicates that many of the funding policy reforms are very active and ongoing. I will draw your attention to the middle of the slide deck, which does point to some of the problems with our findings, in that most of the studies do emanate from the United States. So the vast majority of the evidence is coming from a commercially insured market, and or a mix of public and commercially insured market like the United States is, and less so from the other countries we also found. So there are a number from the Netherlands, Ireland, Italy, a handful from the UK, and 2 studies from Canada as well too. What we did find, though, that there were 2 classes of models that we found, and one is proverbially named the bundled payment. So the bundled payment, that is, and I'll get into this a little bit more depth, is that it's a single episodic based payment for care across a defined period of time. So that is, you're trying to get the care providers to work together to improve outcomes for, say, 30 days, including a hospitalization. The second class of models that we found were most common were called accountable care organizations, using their moniker from the United States. However, they also have a broader name, which could be a capitated or a per person based model, wherein a group of healthcare providers comes together to accept the financial accountabilities associated with clinical care for a defined period, and that's usually a year in time. So within that, opening the hood on bundled payments, and I'm borrowing from a colleague, Eric Helston's slide that he put together, is that a bundled payment is not a bundled payment, in that there are very many different flavors of bundled payments. And all of these on this scatter plot almost is a type of a bundled payment, in that some bundled payments can run for a year, such as the diabetes bundled payment. These are also popping up in the NHS in the UK now, for MS care as well too, cystic fibrosis as well too. And these incorporate either different settings of care or different providers over different settings. Whereas bundled payments that we're seeing most commonly in the United States include physicians, hospitals, and post-acute care or an episode of care, which may be, an elective joint procedure that occurs at the hospital. So that includes the surgeon, the anesthetist, the hospital, and then all of the post-acute care associated with that, which can include inpatient rehabilitation or physiotherapy at home, home care, what have you. So there's a lot of variation associated with bundled payments as well. So bundled payments predominantly were identified for acute conditions or an episode of care. So we did see these were very common for joint replacements, either knee, hip, shoulder, elbow, and there were hundreds of them in the United States. And some of the studies we found were secondary studies that incorporated evidence from a number of sources to drive their conclusions. And the objective of bundled payments is to reduce the fragmentation between sectors or the continuity, the integration of care, and to drive out ineffective care. Because with the single payment for an episode of care, it's up to the providers to determine the mix of services and skills that are provided within this episode of care. And then they would retain the savings between what it costs the providers versus what the funder was paying them. And we are seeing, and I'll get into this in a little bit later, we are seeing a little bit of this in Ontario with its limited bundled payment program, where they include hospital and post-acute care, which would include home care within a single payment. Almost all examples that we saw include physician remuneration within a bundle. So that is that physician payment, which in the Canadian context would be a fee-for-service payment for specialty and or primary care, would be included within this episodic payment as well. Now, what's the impact of bundled payments on providers? The behavioral response is to get the providers to work together to reduce fragmentation, to improve the value or the provision, increase the provision of effective care, and also to improve the coordination of care between sectors as the handoffs between, say, hospital and post-acute care. The second broad class of payment reforms or funding models that we saw are under this broad rubric of capitated or accountable care organizations. So here there are many different, or a number of different objectives, but first among them includes improving the health of the population by driving down not only disparities, but also to improve or decreasing their need for health services. And that's essentially how they would make money in a commercial market, is that if they are able to improve the health of the population, there's less demand for primary and secondary care, thus resulting in savings to the providers here. So the dual objective there is to reduce unnecessary or ineffective care as well. And these tend to be provided on one or multi-year programs that we're seeing coming out of the United States. And we're also seeing a fair amount of this in the Netherlands for a number of chronic diseases. And the way that they work is that there is an established panel of residents and or patients, as most of the literature says, and that the providers that join together in these capitated models share the financial risks for all of the healthcare spendings. And if they are able to improve or decrease the spending on this panel of patients, they are able to retain some portion of the savings for them. Now, what we did see is that these capitated models are primarily focused on the treatment and management of chronic conditions. So this would include diabetes, cystic fibrosis, MS. There were a number of other ones that we saw as well too. And the way that they work mechanically is that there are annual payments by the healthcare funder. In the context of Canada, that would be the provincial ministries of health or their regional agencies associated with payments to healthcare providers for looking after all healthcare needs of those patients for a year, essentially. But the amounts are dispersed over a year in 12 equal payments. There are some nascent movements, as alluded to in the last presentation by Joan, in terms of the development of Ontario health teams. And this is very much in the vein of what's happened in the United States with accountable care organizations, in that they are developing attributable populations. So that means establishing panels of residents who seek healthcare in geographically contained areas primarily, and that these Ontario health teams would then be responsible or accountable for the spending on the health services for the population within their network. And the spending is then observable at the funder level or at the Ontario Ministry of Health level. And although these are off to a very slow start because of COVID-19, there are 34 Ontario health teams that have been selected through a process designed by the Ministry of Health to move these forward to improve the health of the population and reduce the fragmentation and improve coordination and integration of care. So there are some steps in that direction starting in Ontario. And here are some of the early pieces that I put together around lessons for Canada, is that there are a pretty significant range of plausible funding models available to healthcare funders, which may be regions and or provincial governments. I would say that the evidence of the model's effectiveness is either weak or emerging, in that a lot of these reforms are very recent, so it's hard to get a good sense of what the evidence is going to be like several years after looking after population health, for example. So it's a little bit unclear as of yet of whether or not they're going to be effective, although we do see some stronger signals coming out of bundled payments that they are being effective. We also have found some evidence in the papers that we reviewed that context, which means the environment in which they operate, and also social care appear to be very important to the success of these funding models as well too. And that doesn't harken well for Canada, where social care and healthcare tend to be siloed themselves. So it's hard to say what the impact would be in Canada. Contributing to the complex environment is that we currently see very little or no clear articulation of the objectives from healthcare policymakers from exactly what they want from their healthcare providers. So it's difficult to say which funding model best fits the purpose currently, because we just don't know exactly what governments want to achieve other than a long list of 30 items right now. And integration is one, but reducing ineffective care is another. So there's a long laundry list of items. And I think if a government were very clear about which objective it wanted to target, we could align associated with that. I would also say, importantly, that integrated information system, which are a problem in most provinces, has not shown to be a barrier to funding model implementation. So that is a good sign for Canada as well too. And lastly, I'll bring up that the transition between funding models and their policy objectives are very bumpy, in that it's very difficult to transition, say, from a silo-based system to an integrated care model. And also that many of the successful models are led by physicians nominally, or certainly have the broad support of physicians. And I'd like to conclude with offering up my email address if anyone wants to follow up there. So thank you very much.
Thank you, Jason. And I will ask you to replicate your email address in the chat. And we are going to our last speaker of this session before we move to the Q&A session. So last but certainly not least is Joni Cranston, who's one of our patient partners that sits on the Pan-Canadian Advisory Panel for the network. So Joni, I think you have some thoughts you'd like to share with us.
Yes, thank you, Jillian. I don't have formal slides, but I'll just talk like I always do, but I kind of did write some notes so that I will keep on track. And I'll try not to talk for too long so that we have a little bit of chance for discussion afterwards. But so I want to bring you my patient perspective from the Rock, from Newfoundland, out in the wild Atlantic Ocean. Thanks for the opportunity to add my perspective as patient partner to this discussion. So I have been a patient. We're all patients. I had chronic pain in my hip for 20 years, had a hip replacement, and I've just been continually improving ever since. It's sort of like the fountain of youth. Everybody should have one. Then I've also been a caregiver to family members, and I've seen the value of the truly integrated care that was provided to my father when he was dying. He passed away at home in Victoria, BC, and the care was excellent. It was seamless, it was comprehensive, and it was focused on him. So that hats off to BC. They do have some well integrated systems there. I'm also a clinician, a physiotherapist. And when I speak, I always try to speak on behalf of my patients. They're all formally or informally my partners. I usually call them my people. During their treatments, which last about 45 minutes, we talk about everything, and especially about different aspects of healthcare and what they feel about the care they're receiving and what they would like to see and any thoughts and ideas that they have. And I find that they always provide me with really valuable insights. So I like to bring their views to all the tables where I sit on committees and councils. So there are kind of those two perspectives I want to share with you today. One, the perspective of my patients, and then I also want to share some perspectives as a practitioner that would practice in this kind of integrated care model. And in the area where I live, we're forming actually a health collective, which is sort of an integrated model of care. So I'm going to share some perspectives from the collective as well. I would like to introduce you to a community development model that I think it embodies the principles of successful integrated care. I think the healthcare system, there's lots of lessons we could use from community development, which seems to have a more community focus and have evolved over the years in that way. And if I have time, I would like to share some information about the Great Northern Peninsula Community Place project that I'm currently working on now. And the timing for this workshop is excellent, as well as I think the time that we're all living in, because what I'm working with a group of people on the Great Northern Peninsula of Newfoundland is to establish a new clinic that embodies an integrated aspect of care. So I can take all the lessons that I've learned here today and that we're learning just through going through a pandemic and incorporate that into the new model so that I'm building it as we go. So first of all, I want to share my perspective about what my patients and my people are saying about integrated care. They do want to see a truly integrated system, one where all the providers that are involved in their care are sharing information and working together to achieve the goals. They want to see results. They want to see improvements in their health as a result of these teams working together. And I truly believe that if teams are working together and care is truly integrated, that patients are going to see the results. They will have the benefits. They want to see the care integrated into their communities, especially in a rural area. They always have to travel everywhere to access care, but there are elements of care that could be integrated into the community because patients know the role that these social determinants of health play in their health and in their health care. So they want to see these things integrated into the system as well. Safe, affordable housing, access to good food and nutrition, safe, accessible communities. All these things contribute to their health. And when these aspects are integrated into the care model, I think you see better outcomes. They want to be at the center of the care that's provided. They don't want to have to navigate complex systems. I mean, just the systems that we're talking about today are very complex, and patients, they do actually have to navigate these systems. They have to figure out where their square peg can fit into a round hole. I tell them it's like playing chess. Pick your next move and be very strategic about it. So they actually want to see the systems set up around their needs and their timelines that make sense to them and make sense to them with managing their condition. They don't want to have to always be on a 2 to 3 year wait list for a joint replacement when that's negatively affecting their quality of life, and then their cardiovascular status goes down, their diabetes goes through the roof. They want systems to kind of be more receptive and responsive to meet their needs. Systems are very, very complex now, especially systems that are designed from the top down. So if we could take a more community-based or patient-focused approach, I think we could evolve simpler systems that may be easier to manage. Patients want education with regard to the condition and all the choices and outcomes and treatment approaches that are available to them so that they can make informed decisions. They want to maintain their autonomy in the management of their own health. They want to be empowered to make the right choices. Above all, they want to be treated with the respect that they deserve. And you know what? They truly appreciate practitioners who care. That's what it is really about. It's about the care that's in healthcare, and a truly integrated healthcare system has to have integrated elements those care elements into it, not just processing, not just numbers. It has to truly integrate that care. As a practitioner, it sometimes feels like I'm beating my head against the wall of a system that isn't meeting my needs or the needs of my patients. In my dream world, and as much as possible in the real world that I live and work in, and I do live in a dream world, I live on the rural coast of Newfoundland, and it is beautiful, and there's a great team of people here I can work with, and I know that I can truly make a difference in the lives of my patients. So it is my dream world. But I try to work collaboratively with all the other practitioners, doctors, nurses, the dentist, other allied health professionals, allopathic as well as naturopathic and complementary therapists. This all works together to help our patients improve. When I do that successfully, we see the benefits. I see it, my patients see it, and that's its own reward. So the main focus of my treatments is my patients and their response to the treatment that they're receiving. So I integrate their feedback into everything I do. How were you after the last treatment? What helped? What hurt? Who else do you need to see? So I think a truly integrated healthcare system has to find a way to integrate feedback and responses from the patients in real time, so that as they're responding to improvements in the system and as they're improving, we can build on those responses instead of continually going down paths that don't seem to be able to meet people's needs. So an integrated system has to integrate the feedback at every step of the way. An orthopedic surgeon told me many years ago, just listen to your patient. They'll tell you what's wrong and they'll give you the answer. They will tell you what needs to happen here. And I've taken this approach and it's saved me a ton of time and stress over the years. People really do know what they need. We just have to take the time to listen and to ask. Another practitioner in the Health Collective said that integrated care is the combination of movement, mindset, nutrition, and community. All these aspects of health and wellness depend on these four things: mental health, physical health, emotional well-being, a sense of community. This is all part of it. When you integrate those things together, then you get better results. She mentioned that we have a wonderful range of professionals in our region, and if we combine them all and we work collaboratively together, we will probably be able to see the impact that we can make on our region. Because right now we're sort of operating in a little bit of a vacuum. The health system is providing hospital services, but is not providing community-based services. So if we can start something and work truly in the community, we will be able to see the impact. And we're often left out because we're perceived as rural and remote and not a perceived lack of resources. Whereas I think if we look around our region, we go, oh, we have a naturopath and a doctor and a nurse and a dentist and a physiotherapist and a chiropractor. When we see the assets we have, when we work together, then again, we can make an impact. So the model of community development that I referred to earlier is called the PLACE model of community development. And it was created by Dr. Natalie Slowinski. She's a social enterprise researcher with the Faculty of Business at Memorial University in St. John's. And it's based on her research that she did with the Shorefast Foundation on Fogo Island for 7 years. Fogo Island has that famous Fogo Island Inn built by Zita Cobb. So that's kind of an icon that some people may identify with. But so Shorefast has had a successful development on Fogo Island, and it's based on the principles of the PLACE model. So the P stands for passionate people. The people who work in the system are part of the system, and a truly integrated system takes the skills and passion of those health practitioners and really utilizes them to the full extent. So allowing them to practice to their full scope. And P also stands for the kind of place, I think, integrated services when they can be around a place, a community, a building, a center, much more so than a region. That's harder to integrate. But if you can kind of integrate around a place that has meaning to the community that you're serving, I think it's very helpful. L is for linkages between insiders and outsiders from a community and also within the community. And for me, it's integration, linkages between the sectors, between health, between the social sectors, between the business sectors, between the community development sectors, because they can all play a role in creating a stronger system. A is about assets, looking around at what you have. I actually work in an old cottage hospital in North Point, which is a wonderful asset. It's a beautiful building and it's got so much history. And then, you know, we have the farmer who's going to grow microgreens down in the basement, and we have all these assets that we pull together to create a system. C is for the communication, very important between team members, collaboration, about the compassion, about community, and about collective impact. So collective impact is how community development would describe integrated care. I think that we're all working together. And E is for engaging, empowering, and enriching patients. So how am I doing? Is that enough, or do I have 2 more minutes to talk about the project?
We are almost at 10 past, so
We'll stop.
we're a bit short on time. However, I encourage everybody to look at our website. Some of Joni's work is highlighted there, and I'm hopeful Joni will be interviewing with me soon in a podcast, so you can hear more about her amazing work. And I think one of these things, if I'll ask the rest of our panelists to put their videos back on, I think one of the things that Joni has quite clearly demonstrated is if we want to move ahead with integrated care, the patient partner or the community member partner really has valuable insights. And not only that, they're really keen to make this work, and they're doing things that are working. So it was really interesting to hear all the different aspects, the lenses we're bringing to this integrated care. I don't think anybody disputes that integrated care is the way forward. I would remind people, although it's been disputed and it hasn't been updated since 1948, the WHO definition of health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So I think that a lot of the work we're doing in primary care and we're trying to accomplish through our network is addressing the notion of health, and integrated care is essential to that. So, but what you've also heard is it's really complicated, and there's a lot of drivers to it, not the least of which is the payment model. I was really happy to see Jason's work. I often think in our healthcare system, it's the tail wagging the dog, where how we pay people and what we do in that environment has way more influence on what is happening than what our objectives should be. But as Jason noted, it's not clear that what the objective is, like where should we be going to? So how do we measure if we get there? And we all know what happens when you don't know where you're going, where you usually end up. So I really appreciated those comments and all the integration. I think, Joni, we probably need to do another patient partner one to hear even more exciting stuff going on there. So we do have 2 questions, which we do have time to get to. So Lenora Brace has asked if you can describe BC's value-based care. And I'm interested in that answer because I think this notion of what is value-based care is and whose value are we talking about? So I don't know, Nellie or Jason, if you want, or who wants to take a stab at that one first?
I can take a stab first with regards to distinctly what we found. So it's value-based compensation that looks compensation based on quality indicators and panel size as opposed to fee for service. But I have to say that this is very early days, and I have not seen necessarily this in practice. And Jason may have some more to add to that.
Jason?
I don't actually. I have not seen it moving fulsomely ahead.
That's interesting because it's a term that's been around a long time, and it's a sort of a buzzword that people love to refer to. Okay, the next question is, Joan, has your work been published? And if so, where? That's usually an easy
That's a
question.
nasty question. No, we, the short answer is no. And what we're now doing in light of all the Ontario health teams and everything that's going on, we're going to update our search again and because it's 2 years older. I don't know how old it is. So But certainly whoever's sent that question, I'd be pleased to share some of our old findings with you.
Okay, great. So again, you can see the email addresses in the chat. So take a note of that. And you can just, if you're interested,
Yes.
shoot Joan an email and say, when it's available, please let us know. I'm going to ask a question of each of our panelists. I'm going to go in reverse order. So Joni, you're going to answer first, and then we'll go in the reverse order of the speakers. COVID-19 has really, if you think of our healthcare system as an anthill, COVID-19 really kicked the anthill, and there's a lot of things that happened almost overnight, including a massive uptake in telehealth, a lot of different programs that were tossed on their ear, a lot of people scrambling to make things work. I would like to know what you think the impact, and whether that's good or bad, COVID-19 has had like on integrated care, and or if you have thoughts about where we need to be focusing now, given that everything's been turned on its ear in terms of healthcare system organization or healthcare delivery. So Joni, you have some ideas about what you think might be some good things to come out of COVID-19 and integrated care? Why don't you go ahead and start, and I will be asking Jason next.
Sure, there's a silver lining in every COVID cloud. And I think one of the silver linings is that we've truly, especially in our first lockdown here in Newfoundland, people's care really suffered because nobody would go to the hospital with their heart attack symptoms, with their stroke, with their broken hip, because hospitals were seen as places of disease, which is really what they were designed for. They weren't designed as places of wellness. So then as we opened up, people could start receiving their care. And where did they want to go to their care? They wanted to go to places in the community. And then, but it did highlight the need for that integration of care between the doctors who are in the hospitals and, between the whole system. It really highlighted the need for where the integrated primary care needs to be. Needs to be in the community, but it needs to be better integrated. And telehealth is a tool that here on the coast of Newfoundland, it's still the telephone.
Yeah, I'm for those of you that don't know, I'm actually currently based in the US, and there was just the compensation came out, and they're looking at doing away with, they were paying for telehealth and rural health, which was a great boon because people didn't have to travel, right? So suddenly people had more access to care. And those payment codes are going to be disappearing when they consider it an end of the public emergency. Now, what that date is, we don't know. So Jason, do you have some comments to make in light of COVID integrated care and what you're looking at for funding models?
I might slightly reframe it in that I'm also a little bit pessimistic at COVID-19's sort of upending of the delivery of healthcare will stick, other than telehealth, which I think on the margin will improve access via telehealth services, although there may be further disparities with access to, say, advanced imaging, laboratory tests that will still drive people into the urban cores. So I don't know, but I am a little bit, building off of what Joni noted there, that people avoided the hospitals. From a health system perspective, though, we were still paying full freight for those hospitals and all the people that work in those hospitals. So our healthcare expenditures really only went up. So my concerns are that it will, it did nothing to erode the silos between care yet. And I haven't seen a lot of evidence for that the substantive silos, although there may be some gains with telehealth, I acknowledge that, and I hope that they stick, really did little to erode barriers between physician care, say pharmaceutical care, hospital-based care, and long-term care, and the way that they fund it, because the way that those institutions continue to be paid, it has not changed associated with any changes in their delivery. And it could just be a matter of that the funding reforms will have to follow if the delivery changes stick. But I'm not all that confident that they will, given that, again, there's a lack of clear policy or priority articulation, in that the government's not saying clearly what they want from the delivery system associated with the changes induced by COVID-19. So I hope for the best, but I'm a little skeptical right now.
Interesting you noted that because what that happened in the research world is right. Well, right. We had to halt all data collection, but we couldn't fire all of our research staff, nor would we want to. So we were paying ongoing costs without any data accumulation. And that's going to set us back for quite a while. So on both sides of the equation, both evidence generation and the healthcare utilization, that's fascinating. Yeah, and I think people aren't aware that even when hospitals emptied out and it became like deserted, still paying staff to be there. So at a not insignificant cost. I'm on the fence. I'm on the fence about how this is going to play out. So Joan, you got some insight there you'd like to share?
With respect to COVID and integration, I think what we experienced in Ontario certainly was similar across Canada. But I think the ability to do virtual care, the need for strong information systems where there's a flow of information, was certainly highlighted in a public health emergency, so that you need to know who's got a test, who's got the vaccine. From a research perspective, I'm the site director for ICES Queens here. So the whole ICES community, which uses health administrative data, they were getting data right away to do research, which was a real plus. So that I think is something that will be lasting after COVID. With respect to integration, I think my optimistic hat would say that as we're talking about the Ontario health teams and funding, and well, the funding models won't change, and I think that's a huge barrier, but what we're seeing is a little bit more awareness or flexibility for roles to be really optimized within the current structures. You know, when I'm thinking of a nursing role within in the home care, they're now embedded within the primary, some are now embedded within the primary care setting. So whereas before they were distant. So I think that's a plus. But with respect to the the whole hospital-based focus and continuing to have our resources and funding models predominantly in the hospital, I'm as pessimistic as Jason.
Yeah. So for those of you who might not be from Canada or who are not a researcher, ICES is actually the new name for the Institute of Clinical and Evaluative Sciences,
Yep,
and their data repository linking health data. Yeah, and this is one thing I think I'm hoping, again, I'm trying to be optimistic that for the research world, this will convey the message that our data needs to be far more accessible and far more timely and responsive.
And across Canada.
Yeah, across Canada. And also what COVID has clearly demonstrated, I mean, you're talking about integrated care within a health system. COVID has clearly demonstrated that we can't ignore economic factors, social factors, environmental factors. You know, people do not exist much the same way hospitals don't exist in silos. People don't exist outside of context. And so we'll see what happens. We're part of a natural experiment, unfortunately. Nellie, some final thoughts for us?
So just a few thoughts on that, on your question. You know, I think there's, COVID has, just as virtual care, it has presented opportunities for integration and for certain sectors and departments, at programs, et cetera, to work together that never happened before. And so if it can happen, then how do we maintain those so how do we learn from those lessons, and how do we maintain some of those pieces and move that forward instead of then moving backwards? So I'm not super optimistic, but I think that there is opportunities, and I have to just, and I will put in the chat box, but the BC Rural Coordination Center and the First Nations Health Authority held a large online summit in BC in June. And this was the exact purpose of that summit. So there were 900 people virtually, and really looked at how do we maintain what's worked well, and how do we continue to move forward. So there is a final report. I will put that in the chat.
Thank you. That'd be appreciated. I think that this is the thing, and why in primary care research we're hosting these webinars and trying to promote this information, because we need to get that evidence out there ahead. We need to get ahead of this bit of train wreck that's been our last year, and be there and be ready when policymakers move out of panic mode, and that when we are sort of trying to establish what is our new normal, that it really keeps some of the things that worked, and that we don't try and go back to everything as it was, because I think it was quite clear, and COVID made quite clear, that everything as it was can't cope with this level of emergency, and is not doing well on promoting health. We might be really good at acute disease care for a specific time period, but where there's a lot of things we're missing out on. I would like to remind everybody we have our next webinar. Nick has posted it in the chat, is March 23rd. And we'll be talking about end-of-life care in primary care. And there's some really interesting, I think Canada is a leader in some of these efforts, and you'll hear some really interesting work there. I would like to thank our funders. We are funded and supported by the Canadian Institutes for Health Research as part of their strategy for patient-oriented research. We are all partnered funded, so from the network coordinating office to the different sites to sometimes even our own researchers, we have a lot of funding partners who have chipped in to make this work possible. And we would like to acknowledge and thank them. And I'd like to thank all of our speakers for taking the time to join us today and share your work. I think this topic is really front and center moving ahead with our research agenda, and our the work that we're doing on the front lines and in healthcare. And so Nellie has said that she didn't have the report quite as handy, but if you if you go onto our website, you'll see contact us. You can ask for this, or I believe, Nellie, did you put your email in the chat? You can directly email Nellie to ask for that report. With that, we will end right on time. Thank you, everybody, for joining us today, and look forward to seeing you at the next seminar. Thank you. Bye-bye.